My name is Kelly Lovelace. I'm going to be discussing with you dermatology for the internist. Title of today's talk is Differentiating Emergencies from Routine Rashes. So we're going to do an overview quickly of the talk. First thing we're going to review is the most common drug rash we're going to see, which is a morbilliform drug rash. And then we're going to talk about differentiating that from a more serious group of rashes called severe cutaneous adverse reactions, also known as SCAR. We will not cover every SCAR category rash, but we'll cover the ones pertinent to this talk. Next, we'll talk about erythroderma and the causes for that. We'll also then cover dangerous presentations of common skin disorders, including pustular psoriasis and eczema herpeticum. And then we'll differentiate dangerous from common skin disorders, including leukocytoclastic vasculitis and HENOCH purpura, as well as STASIS dermatitis. So in drug reactions, they're extremely common. In most cases, it's just a generalized maculopapular or morbilliform type rash. It's usually mild and self-limited once you stop the medication that has caused it. However, you will see in a small fraction, this drug hypersensitivity shows up as a severe drug reaction. And these severe reactions that are life-threatening are termed as severe cutaneous adverse reactions or SCARs. So first, this is a photo of a morbilliform drug rash. So morbilliform means it looks like measles. Luckily, we don't see a lot of measles anymore because of the vaccines. However, they tend to be erythematous, macules, and papules. They do itch instead of hurt, and that's one of our big differentiations between a morbilliform drug rash and a SCAR. In addition, just to note, this is 95% of all drug reactions. So when you are in clinic and you have a patient coming in with a drug reaction, luckily, this is going to be the most common type that you see. A couple more pictures. This shows you that it has a widespread truncal distribution. It also can extend to the head and the extremities. So next, we're going to talk about the severe cutaneous adverse reactions. We're going to cover 4 different types. The first would be Stevens-Johnson syndrome, and the disease process that it tends to overlap with, which is toxic epidermal necrolysis. Those are considered to be a spectrum of disorders, so there is a generous amount of overlap. However, you can typically differentiate the two, so we're going to talk about how to do so, as it does have an impact on the prognosis for the patient. We're also going to cover drug rash with eosinophilia and systemic symptoms. That is, the shortened version of that is DRESS, which I will use a lot because it's a mouthful to say. And then acute generalized eruptive pustulosis, or AGEP. So the first is this spectrum of diseases with Stevens-Johnson syndrome and toxic epidermal necrolysis. I'll be the first to tell you these are often confused, and I quite often hear doctors probably use the wrong term for what they're trying to say. And that's okay, they're a spectrum, we understand what the point is, but if you can differentiate them and use them appropriately, it does look good. So delineating one from the other, we're going to use percent of body surface area involved, which is called your BSA. Your BSA, or body surface area, is equivalent for 1% is your palm size. So 1 palm is 1% body surface area. So if I was to ask you to look at a patient and tell me the body surface area, you would approximate how many palms of skin in that size are on their body. We also use the areas of skin involved, which are the mucosa versus the cutaneous skin. So Stevens-Johnson syndrome is defined as having less than 10% body surface area with heavy mucosal involvement. And then we have this overlap that we mentioned between the two diseases where 10 to 30% body surface area is involved. And then toxic epidermal necrolysis is defined as over 30% body surface area. These patients have diffuse sloughing of the skin. And while all of the SCARs can be fatal, this one especially has a high fatality rate. The etiology is a little complex. We're not 100% sure always why it happens, because you're going to give a medication to hundreds, if not thousands of patients who will have no problem, and then you give it to another patient and they develop a life-threatening rash. So we do believe it's a combination of the drug structure with the host genetic factors. And those can include how the body is metabolizing the medication, their cellular immunity, and their T cell clonotypes. So it tends to probably be multifactorial why a particular individual will have such a severe reaction. Stevens-Johnson syndrome and toxic epidermal necrolysis from an immunologic standpoint appear to behave most like a delayed type hypersensitivity reaction. This chart reviews what you're going to see on the body. So the first thing you would note is the rash itself. In the early stage, you're going to have flat or slightly raised, and we don't say pink very often, we say erythematous spots with dark red or dusky centers. Next, it progresses to having blistering and peeling of the skin. So early on, you're going to see that sort of atypical annular presentation with that dark dusky center, and that dark dusky center is what eventually starts to blister and then peel. You can see the rash distribution, though, can be very similar to the pictures I showed you for morbilliform rash. So it is important to look at the morphology, what the individual lesions look like, as well as the distribution. On the mucosa, you're going to see redness, blisters, and erosions on the lips and the inside of the mucosa or mouth. And then you're also going to see redness, irritation, and pain, and erosions of the eyelids and the eye. It can also affect the mucosa of the genitalia, making it very painful for these patients to go to the restroom. So on the left of the screen, we have a patient with Stevens-Johnson syndrome with severe erosions of the oral mucosa and the lips. And on the right, we have a patient with those atypical targetoid lesions with dusky centers. And then you can see how it's already progressing to that sloughing of the skin as well as blistering. This is a patient who has toxic epidermal necrolysis, which, as we reviewed, means over 30% body surface area, but they also have widespread erosions. I always think it's important to point out in this picture that they have these leads on the patient, which are adhesive. Those leads, when removed, will rip the skin off of this patient. While sometimes it is necessary to use adhesive bandages or tape in these patients, it should be avoided whenever possible because their skin will rip off anytime these are removed. So it's very important to pay attention to that while offering their care. So our presentation is interesting in that you give the medication, but the rash may not appear for 1 to 3 weeks. If you've ever talked to a patient about starting new medications, they almost always say no, because if they started it more than 1 day ago, to them it's not a new medication. So taking a really good drug history and getting specifics about when medications started is important. I will tell you that I will often contact their pharmacy and get a list of medications and start dates, as patients are not always the most reliable in this situation. Systemic symptoms can precede the skin and mucous membrane findings by 1 to 3 days, and these can include pain of the skin. Remember, that's different than the morbilliform eruption that itches. They can have pain of their eyes and other mucous membranes, headaches, rhinitis, malaise, sore throat, cough, and myalgias. I will take a second to note in the environment that we're in, and the whole reason you're having to have this lecture online, I think, is that we are in the COVID pandemic, and that presentation can be very similar for Stevens-Johnson syndrome as we see for COVID. And I have had some doctors who work in the hospitals tell me they've had patients present with Stevens-Johnson syndrome. However, initially they were thought to be a COVID patient because of the presentation, and not until the skin rash presented were they able to differentiate the two. The hallmark feature of Stevens-Johnson syndrome and toxic epidermal necrolysis is mucosal involvement. Skin lesions are erythematous, irregularly shaped, dusky to red purpuric macules, which I also refer to as atypical targets, which progressively coalesce or combine together. It can rapidly spread to the rest of the body. And then next is a very important clinical feature called a Nikolsky sign. Nikolsky sign is when you push on the skin and you can slip away the upper layers of the skin from the lower layers. So just like we talked about how the adhesive easily removes the skin, you can do the same thing just with your thumb. It's an important clinical finding when you're evaluating a patient for possible Stevens-Johnson's or TEN. Take your thumb and push with some firmness, If they have this disease, most of the time, you'll see that skin slough right off. And one more time to mention, pain is much more prominent than itch compared to morbilliform eruptions. Next is the medications that cause Stevens-Johnson syndrome, toxic epidermal necrolysis. These are very common medications. It is certainly not all inclusive. They use the very cute abbreviation of STATIN. And the first is sulfonamides. Next, allopurinol, especially in higher doses. Tetracycline antibiotics. However, it's also other antibiotics, including penicillins, cephalosporins, quinolones, and minocycline, which is a tetracycline. Anticonvulsants, non-steroidal anti-inflammatory drugs, and nevirapine, which is a non-nucleoside reverse transcriptase inhibitor. So when you see a patient in the hospital and you are concerned that they have Stevens-Johnson syndrome or toxic epidermal necrolysis, we'll often use a measure called score 10 to decide the severity of the illness. It's also to give us an idea of prognosis. The score is determined by the number of risk factors that are present. The higher the score, the greater the mortality rate for the patient. And the absence of a risk factor is scored as 0, and the presence of a risk factor is scored as 1. And the range is from 0 to 7. So next I'm going to show you the score 10 scale. So the risk factors present, if it's 0 to 1, it's a 3% mortality rate. But as you can see, if you have over 5, it's a 90% mortality rate. That is exactly why this is a dermatologic emergency, and it's very important to recognize. So the presence or absence of these factors, they include an age over 40, a current malignancy, total body surface area of over 10%, a heart rate of over 120 beats per minute, a BUN of over 28, serum glucose over 250, and a serum bicarb less than 20. For management, we're not going to cover that in detail in this talk. And the reason for that is that there is no consensus on the best way to handle these patients. However, the very most important thing is to recognize the presentation of these two diseases and to stop the offending drug. That is how you will save these people's lives. Next, you would provide supportive care. Definitely request a dermatology consult if you have them available to you. And then often these patients are transferred to a burn unit or a referral center for management, because as we discussed, some of the more typical things that we do can actually cause these patients some issues such as adhesives, tubing, NG lines. Any of those things can really damage the patient's mucosa or skin. So a burn center or a tertiary care center usually has the ability to manage them better. One more comment I will make for you is that some of the time we will use steroids combined with IVIG or immunosuppressants such as cyclosporin to manage these patients. During the pandemic of COVID, it has sort of been decided amongst dermatologists that if possible, you might consider using IVIG at this time because it is not an immunosuppressant in these patients, as we are trying to avoid immunosuppression while we're dealing with COVID in the hospitals. So we're going to move on to DRESS, or drug reaction with eosinophilia and systemic symptoms. So this is an even more delayed presentation of 3 to 8 weeks. That makes it much more difficult to get a good history from the patient because in their mind, they have absolutely not started a new medication. It can be life-threatening with drug-induced hypersensitivity syndrome with fever, cutaneous eruptions, and internal organ involvement. The involvement of the organs most commonly is going to be liver. That will be followed by kidney, lung, and heart. You do see desquamation of the skin as it resolves, and the mortality rate is around 10%. So these patients have a pretty unique presentation as they present with facial edema that is quite striking, and then an erythematous macular rash with infiltrated papules, which would mean firm to palpation, and a markedly purpuric change of over 50% body surface area. Mucosal lesions are present in more than 50% of patients, and the mouth and the lips are the most common. These patients also almost always have lymphadenopathy, and you can also note hepatosplenomegaly. When you check their blood work, they will have eosinophilia and atypical lymphocytosis. You would also notice an abnormal LFTs if the liver is involved. When I see these patients in clinic, I do, if I have a concern for DRESS, we'll always check that blood work, and it's a very helpful way for me to help rule in or rule out DRESS. So the clinical presentation, you can note the significant facial edema. She does not seem very happy. You see purpuric lesions on the legs. And then although you cannot feel them, you would, if you put your finger on this patient's back, those little papules that you can see would be infiltrated or firm. Medications that cause DRESS have a very high overlap to those that cause Stevens-Johnson syndrome and toxic epidermal necrolysis. They include allopurinol, antibiotics, anti-TB drugs or tuberculosis drugs, anticonvulsants, NSAIDs, and anti-HIV drugs. Again, that's not all inclusive. There are other medications that have been reported. The biggest issue with DRESS, because once you recognize you have a patient with DRESS and you discontinue the medication, you've identified your issue. However, these patients have a very high tendency for DRESS symptoms to recur if they're not treated with steroids for a very extended amount of time. So these patients get high dose, which I would define as 1 milligram per kilogram steroids, with a very long, slow taper over months. And you will find that as you taper that down, they still may have some flaring of symptoms and you have to go back up in order to control them. It is also associated with autoimmune diseases, which is very unique to DRESS. And so we have to monitor for long-term changes in thyroid function, pancreatic involvement, including pancreatitis, and diabetes mellitus type 1. The literature tells us that they think that this could be an activation of HHV6 possibly causing this. They do recommend that you monitor these patients for 1 year after the presentation for these autoimmune diseases. And it's thought that the infiltration of inflammatory cells is what causes the organ involvement, and it's more commonly seen in older patients, whereas these autoimmune changes can be a little more common in younger patients. However, I will tell you in my clinic, I'm going to monitor you for both, no matter what age you are. Next is acute generalized exanthematous pustulosis. That is a handful, so we'll call it AGEP. This one luckily presents very quickly in 1 to 2 days, so it's usually pretty easy to make that association with the new medication. And it is a sudden onset of at least dozens and really normally hundreds of sterile non-follicular pustules. So the reason we say non-follicular is that in folliculitis, the pustule for that is surrounding a follicular structure. These are not. And we describe them in clinic as sheets of pustules. They also have associated fever and neutrophilia. Mucosal regions are rare, and palms and soles are usually not involved. You can, however, see some facial edema, blisters, very atypical target lesions. That sort of overlaps those other conditions we've talked about. And systemic involvement is less than 20% of patients. But again, the liver would be the most common, followed by kidney, lung, and bone marrow. So AGEP can very rarely be caused by a virus, but most commonly it's caused by a medication, with antibiotics being a very common cause of this. And that includes amoxicillin, macrolides, tetracyclines, quinolones, and sulfonamides. You can also see it to hydroxychloroquine, terbinafine, diltiazem, and NSAIDs. And if an antibiotic is the cause, it's usually going to present really fast. If another medication is, it may take up to 2 weeks. This is a great picture of a patient with AGEP where you see those sheets of pustules and also some exfoliation of the skin. There's a close-up of those non-follicular minute pustules. This chart just helps compare those differences between the 3 sets of diseases. The main differentiation really is the onset of eruption, and then the duration of the eruption as well, whereas Stevens-Johnson syndrome and AGEP tend to resolve very quickly. DRESS can continue for weeks, if not months. Fever can be present in all. The infiltrated papules are classic for dress, as well as facial edema is seen mostly in dress. Pustules are seen mostly in AJEP, and blisters are often seen in the Stevens-Johnson's TEN overlap. You can have mucosal lesion in any of them, but you really think about Stevens-Johnson's and TEN. And then lymphadenopathy is much more of a hallmark of dress, as well as you have to remember that systemic involvement can be for Stevens-Johnson's TEN as well as dress. Next, we're going on to a category of diseases with a clinical diagnosis of erythroderma. Erythroderma, however, has 5 main common causes, okay? As a dermatology resident, we have to know those, and we get asked them a lot, and they are medication, eczema, mycosis fungoides, PRP, and psoriasis. Erythroderma is defined of a body surface area of over 90%, so very, very significant. And it's very red. Here's our list of those that I named off for you. So we're going to break those down because I would say that most of you probably would recognize psoriasis and eczema. You've heard about those. Of course, medication reactions, we just covered some of the severe cutaneous medication reactions. But you may not be as familiar with pityriasis rubra-pilaris, or PRP, as well as mycosis fungoides, and a subtype of it called Sézary syndrome. So this is pityriasis rubra-pilaris. Pityriasis rubra-pilaris in individual lesions is described as a nutmeg grater type appearance, but as it extends and coalesces, you get the bright red erythema over 90% body surface area, but these very distinct islands of sparing. So they are bright red, but then you have these very, very clear areas as well, and we say islands of sparing. And these plaques are also tend to be a little bit more of an orange-red color, and then you also often see palmar-plantar involvement. That's another key marker for PRP. Next is mycosis fungoides. Mycosis fungoides is described as poikilodermatous plaques, which means these red plaques you see on the left that have a vascular telangiectatic component to them. And then you can see that it often presents as these large plaques on the right, but it can involve over 90% of the body surface area, especially in a subtype called Sézary syndrome. Sézary syndrome is when the atypical or cancerous cells involve the skin, just like we see in mycosis fungoides. This is made up of cancer cells. However, you also see it in the blood and the lymph nodes in Sézary syndrome. So when we say that one of the top 5 causes of erythroderma is mycosis fungoides, it is often the Sézary syndrome classification or type of mycosis fungoides that causes it. So these patients do not feel well because they have temperature dysregulation because all of their skin is involved, over 90%. They lose a lot of fluid through the skin, a lot of heat through the skin. It causes hypothermia. They often are chilling. They tell you they cannot get warm. They feel pretty miserable. They also lose a lot of fluid through the skin, which causes electrolyte abnormalities, as well as dehydration. And they can also have high output heart failure, which is thought to be due to that red skin that is caused by vasodilation. You also can see hypoalbuminemia from protein loss, and increased metabolic rate causes edema. So these patients are sick, and that high output heart failure does put their life at risk. It's why it's a severe life-threatening dermatologic emergency. You want to recognize those potential causes and do your best to work through which of those it might be. So you identify the cause by using your history. Do they have a history of psoriasis? Do they have a history of eczema? Have they started a new medication? If they also might have some other clinical findings, it might give you a hint So you look at their nails. As you can see, nail changes in psoriasis. You check for lymphadenopathy, which would push you much more towards Sézary syndrome. You look for islands of sparing, which would make you think of pityriasis rubra-pilaris. We often do take a skin biopsy from these patients, and you also will need to take a lymph node biopsy if they have the associated lymphadenopathy to rule out Sézary syndrome. We give these patients supportive care. We use widespread topical steroids, and also we try and treat as specifically as possible to the underlying systemic disease. Next, we're going to cover more emergent presentations of common skin diseases. So at this point in your training, you have probably seen patients with plaque psoriasis, as seen on the left. These are well demarcated with thick micaceous scale. However, psoriasis can evolve into something called pustular psoriasis. Now, pustular psoriasis, although that picture looks similar to the erythroderma patient who could have psoriasis that I told you about, this is different in that it has widespread pustules, which will probably make you think of AGEP as well, very similar look. So pustular psoriasis can have multiple types, but for this talk, we're talking about the life-threatening version, which is generalized pustular psoriasis. It is an acute presentation where a patient with a history of psoriasis undergoes aggravating factors that cause it to progress to pustular psoriasis. However, it can happen in a patient who does not know or have a known history of psoriasis. Most common causes for a patient to present with pustular psoriasis are infections, sunburns, medications, and systemic steroids. So I do think it's important that you recognize that lithium, salicylates, tar, chloroquine, and beta blockers can all cause pustular psoriasis. But in addition, so can systemic steroids. And there are doctors who still will give psoriasis patients shots of steroids or steroid dose packs to calm down their disease. However, you do run the risk that that medication, when it's withdrawn, could make the patient evolve into psoriasis. Next is a dangerous presentation of eczema called eczema herpeticum. So eczema, as you know, can be itchy, well-defined, or ill-defined erythematous scaly patches. The picture I'm showing is actually that of nummular eczema, which is a round, itchy patch of skin. But what can happen is that these patients with eczema, their skin barrier is not healthy. That's one of the reasons they have eczema. So they are more prone to get infections with viruses such as warts or molluscum, as well as bacteria such as staph. But something we don't see as often is a secondary infection with HSV, and that is what eczema herpeticum is. So this is a couple of great pictures, and what's really important about this, and HSV is a herpes simplex virus, that you see punched out ulcerations on their skin. So you may know that the popliteal fosses or the antecubital fosses are very common places to have eczema, but this patient has a presentation where you see these punched out ulcerations with probably secondary infection or impetiginization. But if you recognize it, these punched out ulcerations, it tells you that's likely eczema herpeticum. These patients are treated with an antiviral, and they do very well as long as the disease is recognized quickly. So eczema herpeticum can be severe, and it can progress to a disseminated infection and death if untreated. Bacterial superinfection and bacteremia are usually the complications that cause mortality. So it's not usually the herpes simplex virus itself, it's that secondary bacterial infection and bacteremia that can happen. If you have an immunocompromised patient, the mortality rate could be as high as 6 to 10%. An oral antiviral treatment in healthy outpatients is what we use, often valacyclovir. And if you have an immunosuppressed patient, however, or if you have an infant, you will need to do an IV antiviral. If I have a patient who has this repeatedly or is at high risk for it, such as a wrestler, I will give them preventative oral antivirals to take daily, especially during their sports season, to keep them from breaking out. An eczema herpeticum is pretty common. So when you have an eczema patient who suddenly their treatment regimen is not working, or if they come into the office presenting with blisters and punched out erosions, you really need to be thinking about this potential diagnosis. And the good news is once it's recognized, it really does respond very quickly to treatment. So next is something I wanted to mention because it's something I think that gets confused often in clinic, and that is the difference between Schamberg's purpura versus leukocytoclastic vasculitis or LCV. So Schamberg's purpura are non-palpable purpuric macules, commonly on the lower extremities, whereas LCV is palpable purpuric papules on the lower extremity. And sometimes those can even have pustules in the center of them. So leukocytoclastic vasculitis and then HENOCH-Schonlein purpura are again palpable purpura, and some lesions again can have central pustules. It is a small vessel neutrophilic vasculitis, okay? The difference is with Schamberg's, which is that non-palpable purpura, that is capillaritis, lymphocytes, and just extravasation of red blood cells. That's why you see it. But this leukocytoclastic vasculitis is actually a neutrophilic vasculitis. So that can involve other organs and require sometimes a systemic workup. So it is important to recognize that. But we don't want to be working at patients with HENOCH-Schonlein purpura as a vasculitis patient, because that's just a waste of our resources as they do not have systemic involvement. So for an LCV patient who presents to my clinic, oftentimes I will do blood work to look for renal involvement, because those capillaries that have the neutrophilic vasculitis in the lower extremities are very similar to those small capillaries in the kidneys, and it's usually the most common place that I see changes. So I have them get some blood work done to look at renal involvement, as well as a UA to look for blood or protein in the urine. It is thought that you might want to consider checking a UA for up to 6 months, so doing it monthly for 6 months, as there can be a delayed presentation of renal involvement. If we have a patient with LCV, but we are concerned we have HENOCH-Schonlein purpura, and HENOCH-Schonlein purpura is where we see organ involvement as well as purpura, arthritis, and abdominal pain, as well as hematuria. So they have much more systemic involvement, and the GI presentation for them can be very serious. So if you're concerned about that, if your patient has GI symptoms, we will often do immunofluorescence with a biopsy to look for IgA in those patients. I will say most LCV patients, though, as long as they do not have other systemic concerns, we are not going to do an immunofluorescence. However, if their urine or their blood work for their kidney function comes back abnormal, oftentimes I will go ahead and bring them in to do the biopsy after that to look for the IgA. But for baseline, I do not do immunofluorescence in all LCV patients unless they have other symptoms suggestive of HENOCH-Schonlein purpura. And lastly, we're going to talk about bilateral cellulitis of the lower extremities versus stasis dermatitis or lipodermatosclerosis. So the first thing to comment on is that patients will often present to the ER or to an urgent care with red, swollen lower extremities. And sometimes patients will say that it's a new change, but what we often see in dermatology is they are commonly diagnosed with cellulitis, but they actually have stasis dermatitis instead. So it's important that we try and differentiate those because you do not want to miss cellulitis. However, we also don't want to be giving antibiotics unnecessarily to patients who have stasis dermatitis. So First thing to comment on is that bilateral lower leg cellulitis is actually very rare. So if you see someone and you think that is a diagnosis, make sure you consider the option of stasis dermatitis instead. So the main differentiation clinically is that the patient will be feeling well, they will have no systemic symptoms, they will be afebrile, and if you did do blood work, they will have a normal white count. So they're not acting sick, and they don't have any markers of illness in their blood work, okay? You also probably need to think about getting a good history, and that this patient may have a history of swelling of the lower extremities, and that they may have had some redness or itching in the past, okay? These patients do not need antibiotics if they have stasis dermatitis. Instead, you want to manage the fluid in their lower extremity by doing wraps or compression stockings if tolerated, as well as we use topical steroids to calm down the inflammation. And there is inflammation, it's just not infection. So an antibiotic is not necessary. However, I'm not telling you it couldn't happen. You are certainly going to need to keep cellulitis in your differential, but just be sure to also consider the possibility of stasis dermatitis when you see these patients. So that's the conclusion of my talk. I appreciate you all letting me share it with you. If you all had any concerns, any questions, or if something wasn't clear, please feel free to reach out to me. Otherwise, I wish you the very best.